Ladies and gentlemen, as we are about to begin shortly, please ensure your speakers and internet connection are connected properly to avoid interruptions during our webinar. Throughout the webinar, we will be compiling questions or queries during the Q&A session. Please type your question in the Q&A box, and thank you for your kind operation. So good evening, ladies and gentlemen, distinguished guest professors, lecturers, and our fellow participants. Greatest appreciation to our organizing committee and our collaborators from the REBUNG Cancer Care in the primary care team, University of Malaya and the University of Malaya Medical Center, Project EcoZoom, MMA, FMSA, AFPM, MBPJ, and PERCA B40. I would like to extend a very warm welcome to all of you to the closing of REBUNG Cancer Care in a Primary Care short course. I'm Wilson, Medical Officer from University of Malaya, and I will be your host today. REBUNG Cancer Care in a Primary Care short course is designed and developed by 30 professionals specializing in cancer care to provide primary care doctors with the latest evidence-based screening and early detection methods for the 5 top cancers in Malaysia, namely breast, colorectal, lung, cervical, and prostate cancer. Psychosocial support and navigation support training as well. The online program ran over 7 weeks, and the course was self-paced, 1 to 1.5 hours per week, with an introduction and closing section on the Project EcoZoom platform. The program is an important part of the implementation science program REBUNG, reducing barriers in cancer early diagnosis among urban B40 group from the UMSCR Institute that addresses poor cancer outcomes due to the pervasive delay and advanced career stage of diagnosis in Malaysia. Without further ado, I would like to express a warm welcome to Professor Noor Aisha, a senior consultant breast surgeon at UM who has deep knowledge of cancer health systems in Malaysia and breast cancer survivorship. She is no stranger to the surgical fraternity. Let's welcome Professor Aisha for her welcoming speech.
Thank you, Dr. Wilson. I think I will have to share my slides quickly. Thank you. So good evening, everybody. Thank you very much for making time for this closing today. All right, I'm going to be sharing my slideshow. Can you see it at the moment?
Yes, Prof.
It's still okay. All right. So I think I'll just quickly go through, and then I think I met all of you at the opening, the soft launch that we did end of last year. And again, we want to thank all our stakeholders, the Ministry of Health, especially also MMA. I think Dr. Siva, we are indebted to you to getting us connected with the general practitioners in all over Malaysia. So this project is really, as what Dr. Wilson mentioned, an implementation science, piloting community sites in Petaling Jaya to see how we can work together in reducing cancer early diagnosis barriers among the urban B40 group. And I have to say, without the help of all our colleagues in University Malaya researchers doing many parts of this program, we have actually come up with several outputs from this project, from the REBUNG 1.0 that was carried out in Taman Medan last year. So one of the course that we are doing today, the primary care short course, is really what we want to do in closing the gap for primary care providers to provide cancer early diagnosis in Malaysia. And we have other programs as well. And at the moment, we have the short course for community nurses that is currently taking place in UMMC. And we also have the Rakanku, or the Community Navigator training program, that will take place in June this year. And of course, we will be doing our REBUNG 2.0 strategic communication campaign in a new location, which is Kampung Chepaka, focusing on Mandarin speakers. In REBUNG 1.0, we were looking more into Malay speakers. We will also be translating to Tamil language for REBUNG 2.0. All in all of us are involved in the optimal care pathway of breast, not just breast, or all cancer diagnosis in Malaysia. So primary care, secondary care, tertiary care, we need to work together. So REBUNG actually provides some form of stakeholder analysis looking into all the players and not just the healthcare providers, but also the non-healthcare sector, especially those providing financial supports. So as you can see here, we are hoping by collaborating with all our cancer NGOs, as well as community leaders and our new site, KK Kelana Jaya, and also GPs in Taman Medan and Kelana Jaya, to hopefully can improve the care and the cancer early diagnosis. So as you have gone through the course and you have gone through the section on navigation, we hope that we can provide this network between primary care and secondary care to expedite the pathway. We have done many projects in Taman Medan, where we actually expedited some care in terms of screening mammogram in KK Taman Medan itself to a nearby LPPKN panel hospital, which is the Beacon Hospital. So in this pilot site, we will be digitalizing this optimal care pathway, and we hope to sign an MOU with MPPJ for 5 years to provide this type of care in Petaling Jaya, at least at the beginning. And hopefully we will move on to providing more care and more networks in Selangor and in the Wilayah Persekutuan KL as well as Putrajaya. And I have listed down the grants that have helped us improve and be able to implement all these projects that we've done over the last 2 years. And we have to thank the Impact-Oriented Interdisciplinary Research Grant, the MPPJ SEED grant, as well as the international grant from UICC, as well as the MPPJ SEED grant again in 2022, and of course the Selangor Health Partnership grant in 2023. So this is our new location, and we have had our meetings with the community leaders and cancer NGOs, and we hope to invite all of you, especially the GPs in this area, to come and work with us and see how we can expedite and improve the care pathway for cancer. So I've just listed a few of our clinics that we hope will be able to join us in this optimal care pathway program. We will be using Selangka to help us track our patients and improve access to patient information for the healthcare providers in the health system. So with that, that was my last slide, and I hope you can also review our YouTube channel, the REBUNG Cancer channel. You can share the information with your patients, and hopefully we can together improve health literacy as well as navigation of cancer patients and people in the community to achieve early diagnosis. So with that, thank you very much. That's all from me.
Thank you very much, Prof. Aisha. Next, I would like to introduce our next speaker, Dr. Christine Shamala Savaraj from the Department of Primary Care Medicine, University Malaya. And she is the expert that's actually closest to the community and one of the committee members of our REBUNG Cancer Care. Let's welcome Dr. Christine on the topic, why do we screen for some cancers but not others?
Thank you very much, Dr. Wilson, for that kind introduction. Allow me to request for control of the slides. Yeah? Pardon me, this is a bit... Okay, here we are. All right. Thank you very much, everyone. I'm very grateful to be part of the REBUNG project, and it gives me great pleasure to be with all of you here today at the end of our GP training course. So tonight I'm going to very briefly go through why we screen for some cancers and not others. So this is a brief outline of what I'll be going through today. It's mainly a form of a revision for all of us doctors here. So we're going to go through what screening is and what are some of the benefits of cancer screening, and also what makes a good screening test, because these are core principles we need to ask ourselves whenever we offer screening tests to our patients. So we'll get reacquainted with terminology. And after that, look at some of the harms of screening when it is done inappropriately. and after that, some advances which are on the horizon with respect to screening, and also useful sites for information we can obtain both for ourselves and for our patients. So I'd like to start with a quote by Archie Cochrane and Walter Holland from back in 1971, which actually forms the crux of what screening really is all about, where if a patient were to approach a doctor asking for help, the doctor does the best that he can, and he's not responsible for any defects in medical knowledge. However, if the practitioner were to initiate any form of screening or any procedures, then the story is a different one. A doctor should have conclusive evidence on the screening test and whether it's able to actually alter the course of the disease in order to institute proper intervention. Right? So that's what's so important about screening. And what screening does is actually to identify unrecognized, undiagnosed disease in otherwise well or asymptomatic people by way of examinations or tests or procedures, which can be applied quickly and easily to the target population. So it has to be quick and it has to be easy to be done. And screening is beneficial when it is done appropriately, in the sense that it should be able to detect a disease at its earliest stages so that intervention can be given early and appropriate treatment. So the aim here is to reduce mortality and to increase quality of life. And I think all of you are very well acquainted with the different kinds of screening we offer to our patients. To the general population, what's widely available is screening for cervical cancer, breast cancer, and colorectal cancer. And for individuals in the high risk, lung cancer screening and prostate cancer screening can be offered after counseling and a discussion with your patient before it's carried out. So important terms for us to remember are sensitivity and specificity to start off with. So when a test has a high level of sensitivity, it has a good ability in identifying which individuals have a disease in a particular population, whereas specificity is the test's ability to identify those who do not have the disease. And these figures are compared with the gold standard diagnostic test. And then if we look at positive and negative predictive values, this predicts the likelihood of an individual either having or not having the disease. So allow me to illustrate in this table. Please bear with me. The slides take a bit of time to move. Right. So in this diagram here, I am talking about the Pap smear in comparison to the gold standard diagnostic test. So we have here some figures: sensitivity, specificity, positive and negative predictive values. So if a test has a sensitivity of 83%, it's able to detect here, if let's say 100 people actually have the condition, 83 of them will get a positive result, and the remainder 17 will get a negative result. And if a test is 98% specific and it is carried out in 100 people who do not have the condition, 98 of them will get a negative result and the remaining 2 will get a positive result. Then how do we explain the positive and negative predictive values? Assume that there is one individual, a lady who has done a Pap smear and she's obtained a positive result. What are the chances that she really does have cervical cancer? If the test has a positive predictive value of 80%, then she has an 80% chance of really having cervical cancer, for example. And the same thing works for a negative result. If a person has a negative Pap smear result and the test has a negative predictive value of 97.9%, then that is the likelihood that individual will really not have cervical cancer, for example. So we don't have to remember the figures exactly, but we do need to keep in mind the levels of sensitivity and specificity whenever you offer this test to your patient. Right? So the higher the figures, the better the test is, right? Then that takes us to what a good screening program entails. So for this, we actually do follow the Wilson and Youngner criteria. So of course, a good test that performs well in terms of sensitivity and specificity form an important part of the program. However, it's only useful if it performs at these high levels and is able to detect the disease in its earliest stages so that the disease can be picked up early and appropriate treatment can be given to the patient. That's one of it. The other factors are that it has to be simple, non-invasive, and as low cost as can be. We also look at whether a test is safe. There's no point in encouraging a person to do a particular screening test when its safety levels are in question. So if you compare a simple pinprick blood test versus a test like a colonoscopy or a CT scan, right? So it has to be acceptable, not only for us as doctors, but for the patients as well. And there has to be a good policy in place. So moving on to this. So I'm quite sure that for any of you primary care providers in either the government sector or the private sector, you may have had a request from a patient asking you for, doctor, can I please have a full body checkup or full medical checkup? I want to make sure I'm well. Right? So what do we do? And how do we decide what sort of medical checkup to give a patient, right? So the full checkup usually involves a battery of tests, a battery of examinations as well. Or another term used is the full body scan, where the CT scan, PET scan, or MRI scans are employed. However, these scans are usually used in staging of cancer, making a diagnosis, or planning a biopsy to pinpoint the exact point to get a sample from, or for assessing how effective treatment has been. However, in terms of screening, the literature hasn't been encouraging. Very often you get a lot of inconclusive incidental findings and high false positives. And it is for this reason that it's not recommended in well and asymptomatic patients. So whenever we recommend certain tests or procedures for a patient, it has to be tailored to your patient's risk profile. And another part of it is tumor markers, which are quite often included as part of medical checkup or a health package. And tumor markers, time and again, have not been proven to be very helpful screening tools. Tumor markers are usually used to estimate prognosis of a condition. It helps in staging cancer, detecting cancer after treatment is completed, and how effective it has been. But in terms of screening, it's not sensitive or specific enough. And the tumor markers can actually be falsely raised in benign conditions such as inflammation. Even jaundice can cause falsely elevated tumor markers. So that will unfortunately result in overdiagnosis, which in itself causes problems. Now, screening is very useful, but if done inappropriately, can actually end up doing more harm than good to your patients. And I mean, we must keep in mind and we must remember our responsibilities, and that is to do no harm to our patients. Now, if you were to volunteer or to offer a test which is not really warranted in a patient of yours, for example, a PSA in an otherwise low-risk patient, and if you get a slightly elevated PSA level, generally you're not going to leave these tests alone. You are going to proceed with further investigations to confirm the presence of cancer. And in cases like that, these tests might actually end up causing injury, infection, or bleeding to your patients, anxiety as well. Unwarranted tests can cause a lot of anxiety in our patients, and we mustn't underestimate the toll it can take on someone. Right? An example of a paper done by Fowler and colleagues, where a group of healthy men were subjected to prostate cancer screening, and after that, confirmatory testing. And they were found to have the all clear at the end of the tests, and then they were followed up a year later. it was found that 26% of these well individuals still had a fear of having cancer. And 40% of their spouses or partners also reported having anxiety and stress due to the worry that their partners might still have cancer. So inappropriate screening can actually lead to a lot of over-diagnosis and over-treatment. So as healthcare practitioners, it's a good practice and it's a responsibility that we all have to keep up with improvements in screening and treatment. An example of vaccination programs such as the HPV vaccination program can actually help reduce the cases of number of cases of cervical cancers. And with time, that may actually change the way we conduct screening programs. So we will need to monitor progress with the times. Yeah? And a highly accurate test, I mean, no matter how well it performs, might not necessarily prevent adverse outcomes if effective treatment cannot be given to a patient. So always remember that we should weigh the benefits against the harms whenever we advise or recommend anything. And there are lots of emerging technologies in terms of biomarkers. There are specific biomarkers to specific cancers which are being studied at the moment, and they may perform well, but it also needs to be balanced with factors like cost and whether it is easily accessible to our patients, right? So let's watch this space for more developments. So to summarize my presentation for tonight, appropriate screening saves lives, and screening programs should always be based on current data and effectiveness of testing. And screening, when done inappropriately, can be more harmful than good. And whenever there are any doubts, do have a discussion with your patient about the harms and benefits, and let your patient make an informed decision and ensure that it's a form of shared decision-making and not imposed on your patient. And whenever you need to get any updates or to cross-check any screening modalities, it's good to keep up with current and evidence-based resources. So one example is our REBUNG Cancer Screening Program, and as well as other resources like the US PSTF. So yeah, that's all from me tonight, everybody. Thank you all very much again for inviting me.
Thank you, Dr. Christine, for the insightful talk. Next, I would like to invite Dr. Farhana binti Fadli, our consultant radiologist from the Department of Biomedical Imaging, University of Malaya. Welcome, Dr. Farhana, to deliver her talk on the breast cancer screening.
Thank you very much, Dr. Wilson, and to the committee for the kind invitation to give this short talk about breast cancer screening. I'll just try and share my screen. Okay, I hope everyone can see my screen.
Yes, we can.
Okay, that's great. Okay, so I've been tasked to talk about breast screening. So I'm mainly going to focus on mammography. So, okay, so this is the outline of my talk. I'll be talking about breast cancer and screening mammography, who, when, and how to screen, benefits and limitations of screening in breast cancer, which I'm sure most of you will already know all these things. So just kind of a summary and just a refresher on what you already know. Okay, so just talking about breast cancer in Malaysia, as we all know, it is the frequent cause of cancer deaths in Malaysian women and also worldwide. And in Malaysia, the age standardized incidence rate of breast cancer in 2018 was found to be 47 women per 100,000 population, with a total of 7,500 new cases reported in that year. And it's the most commonly diagnosed cancer in women, 32% of all new cancers. And most of the cancer diagnosis was in stage 2 and also 3. So the incidence of getting breast cancer is in about 1 in 20 in Malaysia, about 5% population risk, which is actually higher when you compare with other countries like the US and Australia and the UK. So looking at the breast cancer screening test, So there are multiple tests that we can do to kind of look for any signs of breast cancer or breast lumps. But the main screening test would be either mammography or MRI. And so why do we screen the patients? This is the population basically is because early detection is the primary way to prevent development of life-threatening breast cancer. And it has been shown that mammography can actually show the abnormality 1 to 2 years before it is actually clinically palpable. So, and detected smaller breast cancers are much more treatable and thus provides a better outcome and survival rates. It has been shown that the 5-year survival rate for stage 0 cancer is actually 100%. And the percentage actually goes down, which when you can look at stage 4, it's actually 19% 5-year survival rate. So breast cancer screening allows secondary prevention. So the main aim is to detect breast cancer early stage and reduce morbidity and mortality from the disease. So as you all already know, digital mammography is consisting of images of the breast created by X-rays, and our two usual projections are the CC, craniocaudal view, and the mediolateral oblique view. So what is mammography? It's actually a low-dose X-ray examination of the breast. So we use as low a dose as we can to get a good image as well. And the X-ray passes through the breast and a detailed picture of the breast tissue is taken. So this is how it's performed. We have a radiographer who actually guides the patient into proper position and then gently compresses the breast between two plates and then take the X-ray image. So what's the diagnostic accuracy of screening mammography? So in the ages of more than 50 years of age, it's about 98%, but in dense breast, the sensitivity goes down a bit to 84%, whereas the specificity runs between 82 to 98%. And as many as 5 to 15% of breast cancers is actually not detected mammographically. So if you see some reports from PPUM, you will notice that we always write this at the end of a report, just to mention that there is a chance that we may not detect the breast cancer. And there is lower sensitivity in dense breast tissue, which I will mention later. So these are the numbers that I mentioned just now in a study actually by our Prof. Aisha in 2011. This is the survival rates for the different stages of breast cancer. And we did also publish a paper in 2019 on opportunistic mammography screening, because as you know, in Malaysia, we don't have a population-based screening, but it's all opportunistic. So we found that in a group of 2,510 women, which were gathered over several years, the average risk at screening was 0.5%, whereas if the patient already had high risk, the cancer detection rate was 1.25%. And then in the younger age group, the cancer detection rate was 0.2%, whereas in the older age group was 0.65%. And we also found more DCIS, the ductal carcinoma in situ, or the stage 0, in the screening group than in the diagnostic group. And early stage breast cancer in stage 0 to 2 was about 85% of this group versus 61% in this will be the diagnostic group. So looking at the subsidized mammography screening program, so a different group of patients compared to what I mentioned earlier, about 1,778 women underwent a clinical breast examination and mammograms, and the cancer detection rate was 0.39%. And we found that about 30.7% of the patients underwent supplemental ultrasound, especially those with dense breast and also with mammographic abnormalities. So when and how often do we screen patients? So of course in US and UK, they have their own program, but in Malaysia, we look at those patients, those women aged 50 to 74 years, and we mammogram them every 2 years. And of course, it depends on the risk as well. So that's in average risk, but if in moderate risk, about at the age of 40 to 49, we would do the mammograms yearly, and then from 50 to 59 would be either yearly or biannually. And then in high risk, it's in the age 30 to 39, may do mammograms yearly, or maybe with MRI as well. But 40 to 59 years of age, we would do it yearly. So what are the benefits of mammogram screening and also the limitations? So the benefits is, of course, reduced breast cancer mortality if we detect it early, and then we can provide less aggressive treatment for the patients, high quality of care. Whereas the limitations are in patients with dense breasts, okay, so sometimes overlapping breast tissue may cause a problem in actually diagnosing any, the abnormality in the breast. And also there can be false positive features, and also there could be overdiagnosis or overtreatment of the patients. Also, some other issues that come up would be interval breast cancer. So maybe we did a mammogram and it was fine, and then in between they get, they come back with a lump breast cancer, and then also increased incidence of DCIS detection, and then increased attention and awareness of breast cancer, which is a good thing. But of course, there is the financial cost involved for doing more screening mammography. So what do we see on mammograms? What do we look for? So we look for any masses, speculated masses, any suspicious calcifications, architectural distortion, or any asymmetry. So we compare both breasts if there are two breasts. And this is an example screening mammogram where we see when we compare both sides, this kind of, it pops out. It looks a bit different from the other side of the breast. Okay, so we compare the images side by side. And here on spot compression, which is an extra view, like just now I mentioned, we do two views, CC view and MLO view. We also can do spot compression for those areas that we are not very sure about. Either we want to look at calcifications more closely, or we want to look at any masses that we noticed. Okay, so microcalcifications as well. This was actually a case with ductal carcinoma in situ. Okay, so pleomorphic calcifications is a term that we like to use, and it means varying sizes and shapes of the calcifications, which is usually quite suspicious. And this is what we do for patients that we see microcalcifications. We will do a stereotactic guided vacuum assisted biopsy. In UM, this is what we do. But of course, other places, maybe what they might do is stereotactic guided core biopsies. And from our vacuum assisted biopsy, where we can get very nice big cores of tissue, and then so we just take out the sample and we actually do a radiograph on the sample itself, and we can make sure that we have got the calcifications, and this turned out to be a ductal carcinoma in situ, so a stage 0 cancer. So moving on to dense breast, which is always an issue, which causes lower mammogram sensitivity and also an increased risk of breast cancer. Okay, so so we can see that the density can cause an 18-fold risk of interval cancer, okay, and also 4.7-fold increase of risk to develop breast cancer. Okay, so this was from some studies that have been done not too long ago. Okay, and talking about breast density, so in each patient, when we do mammogram, we always assess the density of the breast, either A being very fatty or D extremely dense. So there is a range of it. So any patients with C and D, we tend to have to look a bit more closely because they are dense breasts. So maybe adjunct ultrasound may be helpful. Okay, so density is a risk factor actually. So women with high breast density have a 3 to 6-fold greater risk of developing breast cancer than women with low breast density. So for every 1% increase in percent density, there will be a 2% increase in the relative risk of breast cancer. So actually you can do some calculations to actually measure the percentage of density, but we don't do that regularly, more on a research basis. Okay, so what are the limitations of mammogram in dense breast? So it can have false negative cases. So we think it's negative, but actually it turned out to be actually having a cancer. And so as I mentioned earlier, regular mammograms, there can be a 5 to 15% false negative rate. And what could be the cause? Maybe because of the dense breast obscuring the lesions, maybe poor positioning, perception error on the side of the radiologist, incorrect interpretation, and also slow growth of the lesion. Okay, so maybe we saw it before and we thought it's quite stable, so probably it's quite all right, but actually it turned out to be cancer. False positive, so we thought that there is cancer, but turned out not to be cancer. So, so this is when we will recall the patient maybe to do another view or to do ultrasound, okay, and then or even maybe we might do biopsy. And so in patients between the age of 40 to 49, when they tend to have more dense breast, so there's a 30% risk of false positive and 7 to 8% chance of having breast biopsy within a 10-year period. And also, when we see microcalcifications, pseudo lesions, we may, want to biopsy, but actually turn out not to be positive. So just final thoughts about breast cancer screening. So screening programs generally will reduce mortality from the disease. And it's a combination of early detection and improved treatment, and the benefits usually outweighs the harms. Of course, it depends on healthcare resources availability as well. And some of the limitations is of high density, okay, and also risk stratification and personalized treatment may reduce the harm and increase the benefit of early detection of breast cancer. So with that, I thank you very much for your attention. And if you have any questions, please put it in the chat box, or you can always email me as well. Thank you.
Thank you, Dr. Farhana, for the interesting pictures and insightful talk. Next, I'll to invite Professor Kong Tak Lun, our consultant colorectal surgeon from the Department of Surgery, University of Malaya. Let's welcome Prof. Kong on his topic on colorectal cancer screening.
Many thanks, Wilson. And first of all, I would like to thank Prof. Aisha and Prof. Sunisa for getting me involved with this project. If I'm not mistaken, if I recall correctly, this started back in 2020. And I have to say, congratulate Prof. Aisha and Prof. Sunisa for how incredible this has actually panned out to be. I have also the privilege of working with these following people who have been the special team who came up with this module. Without their help, this would not have been possible. So I hope that the colleagues who have actually had the opportunity to participate in this module and have learned from this have gained. And if there is anything that's not very clear about, hopefully I can try to target some specific areas I will talk about again this evening, and I'm very open to any questions later on. So the first thing is that management of colorectal cancer and how patients present to us is a real problem. The reason behind this is multifactorial, but ultimately the main problem is that our patients are presenting late and they're being diagnosed late. So this is data from the Malaysian National Cancer Registry. And I would like to highlight here that the alarming rates of patients, male and female, presenting to us as diagnosed colorectal cancer are diagnosed in late stage when there's already lymphovascular invasion and there's also metastatic disease. Clearly, this presents a limitation of what we can do if we wanted to cure them of this condition. And ironically, this disease is actually very curable. If caught early, the disease is easily managed. So just in addition to us picking up these cancers late in Malaysia, then the next harrowing thing is that over time, so we're looking at data here. So the brown bar correlates to data for 5 years from 2007, 2011. And the yellow bar here is data for 2012 to 2016. So over the 5-year period, rather than actually getting better at patients presenting earlier with disease, they're actually presenting later. So this is something that we really need to do something about rather dramatically and drastically. And this is exactly why I have got a keen interest in research in this area. So we clearly need to do something. And how can we all try to improve outcomes for our patients? As I said, the reasons for patients presenting late is multifactorial. So we actually can't blame patients. I have to say, as clinicians, we sometimes have to take some of the blame because patients do present symptomatically to us, but because symptoms associated with colorectal cancer is non-specific, meaning that at some point in time in our lives, we may develop rectal bleeding, some change in our bowel habits, we may have some weight loss and some abdominal pain. It doesn't mean that we have colorectal cancer. It just means that we are having some intrinsic abnormality with our bowel at that moment in time. However, it is important to emphasize that if this problem persists, then this might represent a problem. So therefore, even if patients present with symptoms that are unspecific, if you're not sure, they may just warrant a follow-up, maybe in a few weeks' time to see whether the symptoms resolve. And I agree with you, it is not easy to try to pinpoint patients who have colorectal cancer because the symptoms may be vague. There are these guidelines here in the CPG, and I hope that you have had the opportunity to read up on this on our module, but I hope that this is a bit clearer as to who you need to refer to for urgent expedited investigations. Okay, but I do agree that the whole purpose of today's talk is about bowel screening. And I'm just going to show you some data here to show that there is a lot of data going all the way back to 93 to show that if we actually have fecal occult blood testing used as the first line for detection, early detection of colorectal cancer, it does confer significant benefit. So the reduction in mortality can be dramatic. It can be somewhere up to 13%. And in this study here shown in New England Journal of Medicine, where they followed up patients for 15 years, the reduction in mortality is significant, somewhere within about 30 to 40%. So it does work. Colorectal cancer screening can save lives. So it is harrowing that data which is available 20 years or 30 years ago is still not fully implemented in Malaysia. So why? What is the problem? So we have looked at this in University of Malaya. What we've done is that we have actually distributed IFOBT kits to patients who have just come for routine checkup in the primary health clinics. And really worryingly, out of the 12 patients out of the 125 who returned their FOBT kits, so 10% of these patients actually tested positive. But when they were counseled to come forward for colonoscopy, only 3 came forward, meaning that 75% or 9 of those patients who knew they tested positive preferred not to have a colonoscopy, meaning that they prefer not to know whether they have a situation. So this is a study of students, and he basically looked to see why. Why is it that patients are poorly compliant to screening, despite the fact that they may have tested positive? So this is actually quite revealing that overall, the reasons for why patients don't turn up can be divided into 3 different reasons, major factors. So 1, patient factors, 2, test factors, and 3, healthcare provider factors. So the most common reason for patients saying why they do not want screening or they do not believe in screening is because they personally believe that there's nothing wrong with them. It's because they have no symptoms, right? Because the whole point of doing screening is that these patients are actually asymptomatic. And because they're asymptomatic, everyone thinks that they're well. But the problem is, as we know with colorectal cancer, is that you will only develop symptoms when the stage gets more advanced. So that defeats the point. And so this is very important that we need to emphasize this and educate our patients that asymptomatic, having no symptoms, does not guarantee you that you do not have a risk for bowel cancer. And then the next reason for why they don't participate in it is because they are not being advised by their medical profession. So if they don't have recommendations from you, the GPs looking after these patients, they feel that there's no role in doing it because my doctor doesn't recommend it, right? So what's the point of doing it? And they have a fair point. And this is why where we are at now, and I'm so glad that you've come to join us today, because clearly we all have a shared common interest in trying to relay this information to our patients. The next thing is about fear of procedures and complications, which we have clearly shown in our study with Stephen C's project, that navigation and improving education to patients before they even start bowel screening actually relieves their stress and anxiety of participating in screening. Okay, so those are the 3 main reasons for why patients actually do not want to participate in screening. And clearly these things are that they can be solved quite easily. And this is all about communicating, and it's about teaching our patients and educating them. And this is what we just need to relate to them really simply in just this very simple card that we actually give to our patients. We just need to tell them that even though they're asymptomatic, all of us have a lifetime risk of developing bowel cancer. So we all have about a 6% risk of developing bowel cancer. And the chances of surviving from bowel cancer is really good if it's detected early, and a lot worse if it's detected late. So the key to beating bowel cancer is early diagnosis. And you certainly want to detect the condition before it gives rise to symptoms. And this is the whole purpose of why we do colorectal cancer screening. So just a little quick recap on bowel cancer screening in Malaysia. So we have a two-tier process. The first tier so you need to identify the patients who are suitable for bowel screening initially. So these are patients aged between 50 and 75, and they have to be asymptomatic, and they shouldn't be at higher risk of developing colorectal cancer, meaning that there shouldn't be a very strong family history, or these patients shouldn't have had a past history of colorectal cancer. Then they need to be told that this is a two-tier test, where the first test is normally an FOB test, meaning that they will need to collect some stool and test it. And the reason for this is to test for the presence of blood. If there is presence of blood, then they are highly recommended to undergo a colonoscopy, and they need to be informed that the colonoscopy is a fairly routine test. All it requires is some bowel preparation before. The risk of this procedure is low, meaning that there is only about a 1 in 1,000 chance of perforation and 1 in 500 chance of bleeding. So the overall chance of a major complication is low, and they shouldn't have significant pain or discomfort. And this is done as a day procedure, where they can come on a day and they go home on the same day after having been recovered for several hours in the endoscopy room. And subsequently, they'll be followed up with the results of these tests. So it's a very simple message to pass on to our patients. This has to be relayed accurately so that they're given the right information to make the right decisions. So hopefully that was a very quick snippet of bowel cancer screening, and I hope that we will be able to address some of your questions later on. So thank you very much for your attention.
Thank you, Prof. Kong. Next, I have to invite Dr. Teo Yi Hui, our clinical specialist from the Department of Obstetrics and Gynecology from the Faculty of Medicine, to deliver his talk on cervical cancer screening. Welcome, Dr. Teo.
Hi, good evening, everyone. Thank you. Let me share my slides, please. All right. Okay, good evening, everyone. I'm Dr. Teo here. So today I'll be talking about cervical cancer screening, which is a very short, just a recap on what we have spoke about previously. Okay, so the reason cervical screening is one of the most established screening types in Malaysia, simply because it is the easiest to do, the most effective, and cervical cancer is the third most common female cancer in Malaysia, and especially among the reproductive age women of 15 to 44, it is the second most common cancer. So, so now we know that cervical cancer is caused by human papillomavirus. The key word here is the persistent infection of human papillomavirus. So this group of virus is actually a very common group of virus, and most of the time it does not have any, the patient do not complain of any symptoms at all. And it is important when we do the HPV PCR testing that we need to interpret the result very carefully, because most of the tests that we do, you will see that the patient might be positive for the low risk HPV, but what it is important here that we must interpret is the positive of the high risk HPV, especially the 16 and 18, which carries the highest risk of for cervical cancer. So when we talk to the patient, it is important to let them know, communicate with them, to let them know that this HPV infection is actually extremely common among the men and women. So they actually do not have to worry about getting this HPV infection, because most of the time, this HPV infection will go away on its own if the patient has strong immune system in the body. And they do not usually show any signs and symptoms, no pain, no discharge, nothing. So because a lot of misconception happens around the patient, especially when they think that this HPV patient will have a lot of symptoms and is sexually transmitted. So we actually need to educate the patient to let them know that all the misconceptions are actually wrong. So from the time of HPV infection up to the development of the cervical cancer, the duration is actually a very slow process. So it can take up to 10 to 15 years from the acquisition of HPV infection up to the development of cancer. So during this time, we have a lot of opportunity for us to stop the progress. So the earliest what we can do is to introduce HPV vaccination. And if, let's say, the woman has missed the HPV vaccination age, throughout her lifetime, we should do a proper and effective cervical screening. And if unfortunately they've already developed precancer or cancerous lesions, they must seek treatment early. So the most common and the biggest risk of developing cervical cancer for women in Malaysia is when the women do not come forward to do a cervical screening, which is very true, especially among Malaysian women. 3 out of 4 women do not do cervical cancer screening regularly. So most of the most important reason is because cervical cancer screening in Malaysia, it's opportunistic, where we actually expect the patient to come forward for the test instead of a proper screening guideline like the other countries. So all this mainly is because of lack of awareness, stigma, fear of pain, and also embarrassment, because a lot of misconception happens around HPV where patients think that this is a sexually transmitted disease and many other stigma and misinformation. So especially in the primary healthcare, the GPs, all the doctors, we should actually educate the women about what actually is HPV. So once again, cervical cancer screening is very important because cervical cancer can be prevented. And we really hope that we can actually eliminate cervical cancer in our lifetime with 3 very simple steps. Number 1 is HPV vaccination. Number 2 is regular cervical screening using HPV PCR testing. And number 3, early treatment for precancerous or cancer lesions. And this is the 3 global strategy which is recommended by WHO as well as the Ministry of Health of Malaysia. So in Malaysia, we actually have a very established HPV vaccination program, which is started in 2010, and all the girls born after 1997 were vaccinated. However, unfortunately, this program is being stopped during the COVID pandemic. So we really hope that we can actually catch up with this vaccination program. So we have a local data where we analyze the effect of HPV vaccination among Malaysian girls. So it actually shows that there's a tremendous reduction in HPV vaccination, especially the high-risk type, which is the 16 and 18, down to 90%. 90% reduction of this HPV infection, which also can translate into reduction of cervical cancer in the future. And compared to previous time, nowadays we actually do more HPV PCR testing simply because this test is much easier to do, much more sensitive, and the most important is patient can do it themselves compared to Pap smear, where because of the low sensitivity, therefore the number of the tests which needs to be done per lifetime of a woman is much more, which up to 15 times per lifetime. And most of the women are really scared of Pap smears because of the pain, because of the embarrassment, and quite troublesome for them to do because it needs to be done by a healthcare worker. So it is extremely easy to do. Most up to 99% of the women they are able to do it themselves. And the most important thing is HPV PCR testing is more than 90% sensitive compared to Pap smear. So what we need to tell the patient when HPV is detected in them is to tell them that they do not have cancer. We must reassure them that they do not have cancer when it is HPV positive. What they need to do is to let a healthcare worker to examine and at most to perform a colposcopy. And if let's say there are precancerous lesions with early very simple treatment of excision or ablation therapy, the risk of cancer is reduced markedly. And who actually should do this cervical screening? All the women who are sexually exposed from the age of 30 to 65, no matter whether they are HPV vaccinated or unvaccinated, they should actually do HPV PCR testing for cervical screening. So they will only need to do HPV PCR testing only if HPV is detected. Only then, depending on the type of the subtypes of the HPV, if it is 16 and 18, you need to refer them for colposcopy. But if they are high risk but non-16 and 18, what you need to do, you can do a pap smear. If the pap smear is normal, you can just repeat the HPV PCR test in a year's time. And this HPV PCR test is widely available at the moment, not only in PPUM, I think in most of the clinical settings, they are able to do it already. Yep, that's all. Thank you.
All right. Thank you, Dr. Teo, for the interesting talk. Please be informed that throughout the webinar will be compiling questions and queries during the Q&A session. So you can start typing your questions in the Q&A box for now. Next is our case discussion session. I would like to introduce our moderators. Number one is Dr. Sivanesan Lechumanan. He is our Honorary Deputy Secretary from Malaysia Medical Association, who has vast first-hand experience in primary care. And Dr. Teo Lee Ying, our consultant in breast oncoplastic surgery in University Malaya, and also our committee member of REBUNG, and also Dr. Christine, as well to be our moderators. There will be a few panelists for a few specific cancers. I would like to introduce for the panelists for breast cancer will be comprising of Professor Aisha, Dr. Farhana, and of course our Associate Professor, Dr. Suniza bin Jamaris. And panelists for colorectal cancer will be Professor Kong. And panelists for lung cancer, I would like to welcome Professor Dr. Pang Yoke, our consultant respiratory from the medicine unit from the Department of Medicine, Faculty of Medicine, University of Malaya. And also cervical cancer will be headed by Dr. Teo. Prostate cancer will be by our Dr. Ahmad Azran, our consultant urology surgeon from the Department of Surgery, University of Malaya. Psychosocial support will be by Professor Dr. Ng Chong Wang, our consultant psychiatrist from the Department of Psychological Medicine, University of Malaya. And I would like to express my warm welcome to Dr. Shariza Izwan Zainuddin, our consultant palliative medicine from University of Malaya as well. So I will hand over the floor to our moderators. Thank you.
Yeah, thank you very much, Dr. Wilson, for your kind introduction. And thank you so much to all the panelists for being here today. So we will start off our case discussion. So I think today we have 3 cases. And may I invite the first case presenter would be Dr. Noor Faiza. Are you online now?
Yes.
Hi, Faiza. Welcome, and you may proceed with the case presentation, and we shall carry on about the discussion after your presentation. Thanks.
Thank you. Assalamualaikum and a very good evening to all. Thank you for giving me the opportunity to present this case. This case actually I saw about 10 years ago when I did my master's program, and I wrote this case for my case study. So this patient was a 40-year-old lady. She was a housewife. She was actually initially referred to primary care clinic after discharge from the medical ward. She was admitted for severe anemia. HB was 6.1, and she was transfused with 2 pint tight cell during admission. HB post blood transfusion was 8.9. She was on wheelchair during the clinic visit. This was the blood investigation done in the ward. The blood sugar was normal. Serum ferritin was low at 10.1 and albumin was low at 25. Thyroid function was normal. Okay, she actually complained of still having lethargy and dizziness post blood transfusion. She had significant loss of weight and loss of appetite and weight. She had lost about 14 kilogram over 1 month. There was no bowel symptoms, no PR bleeding. She had menorrhagia usually during day 1 to day 5 for many years. For family history, her mother was diagnosed with colorectal cancer at age 50 years old. And she also had 2 sisters diagnosed with colorectal cancer at age 40 plus years old. So when I get this history, I was thinking whether was this patient having colon cancer. For social history, her husband was a wireman. He had 1 son, aged 12 years old. Altogether, she had 7 siblings. She did not smoke and she also didn't consume alcohol. For physical examination, she was cachexed, no jaundice, blood pressure was 100/64, pulse rate 90 per minute. Cardiovascular, respiratory, and CNS examinations were normal. Abdomen, there was liver 2 centimeter palpable. There was a mass at left hypochondrium about 4 times 4 centimeter. On rectal examination, there was no mass or melena. Breast examination, no lumps, no cervical lymph nodes palpable. I repeated the full blood count at that time. Her HB was 7.3. She was seen by gynecologist earlier and endometrial sampling was normal and ultrasound of uterus and ovaries were also normal. So at that time, my provisional diagnosis was colon cancer. So for the management, I actually called the surgeon and also I tried calling gastroenterologist to get an urgent colonoscopy appointment. But they told me that the earliest appointment that they can give me was 2 months. And I told them I cannot wait 2 months. So I tried calling medical team to admit the patient in view of symptomatic anemia for blood transfusion and further investigation. But the medical team also refused to admit her because her HB was 7.3 and was advised to give iron tablet first. So at the end, I sent the patient to surgical clinic on the same day with an urgent referral letter mentioning diagnosis of colon cancer. Initially, I got scolded by the surgery team because the patient looked ill and need to be sent to the emergency first. However, they eventually saw the patient and the patient was then transferred to the surgical ward after review by surgeon. So the colonoscopy that was done in the ward revealed splenic fracture at there was tumor at the splenic fracture and descending colon with multiple polyps at descending colon. Biopsy from the tumor showed moderately differentiated adenocarcinoma. He was transfused with 4 pack cell followed by surgery, which was total colectomy with en bloc resection with distal pancreatectomy, partial gastrectomy, splenectomy, and jejunal resection. He was given parenteral nutrition and chemotherapy. He was admitted for more than 2 months in the ward. However, patient passed away after 10 months of diagnosis of colorectal cancer, leaving behind a 12-year-old son and a husband. So I learned from this case about the diagnostic conundrum and also there was a navigation issues for this patient. I think that's all. Thank you.
Okay. Thank you, Dr. Faiza. You see, we heard the beautiful lectures from all the distinguished speakers just now, but on the ground, this is a reality we face, I guess. I think this is not only from the KK side, but also when sometimes we send cases from the general practitioners of primary care as well. In Selangor, they did the screening of for the B40 group, and quite a number of people was detected to have occult blood and everything. But I agree with Prof. Com that not all are keen to go for a colonoscopy. So I guess they will only turn out to the hospital when they turn to be cases like these, once they are in a very severe problem. Now, how could we overcome this? Does any of the panelists like to address this issue?
Yeah, thanks, Dr. Siva. It's really sad to hear this, actually. She's obviously a young mother, and she's actually died prematurely from colon cancer. So I think there are a few things to take away from this. Firstly, is that the patient actually had anemia, and profound anemia, and there was possibility of menorrhagia, but the question then is, this has been a problem going on for a while. So if she wasn't symptomatic before, then why should she be symptomatic now? So which therefore suggests that there must be something new. And given the fact that she had a palpable mass, so well done, Dr. Faiza, for picking this up. She actually went to the hospital where she was actually transfused with blood. And the doctors, unfortunately, did not recognize that she had a palpable mass. And if this was picked up earlier, then she would have actually not had this delay possibly of eventually getting the right diagnosis and then getting treatment, surgical treatment. So that's the first thing. I think the first thing to take away is that this patient was actually symptomatic. So this patient is not someone who is your run-of-the-mill patient for screening. This is a patient who is screaming at a clinician that I am symptomatic. Please take my symptoms seriously because something is very wrong. I need to have expedited investigations. And Dr. Faiza was absolutely right. But unfortunately, no matter how much she is an advocate for this patient, unfortunately, the specialist didn't quite see the urgency, which is a shame. Secondly, the next thing to take away is that there's a strong family history here. She fulfills the criteria of the Amsterdam criteria for what we would worry is an inheritable bowel cancer, inheritable condition. So she fulfills the 3-2-1. So meaning that there are 3 close relatives, all primary, all within first degree relatives. 2 of them are actually first degree relatives of each other, and it's a successive generation. And furthermore, one of them is aged less than 50. So if anything, I'm worried about the siblings actually that she has. So unfortunately, there's nothing that we can do now for this lady who unfortunately passed away, but we can now certainly think about what we can do for the other siblings, where I would thoroughly recommend they actually get screened. So screened because they are at higher risk for colorectal cancer. Yeah, that's from me, thanks.
Can I just ask the profs, how long, if say a person like this is detected or somebody who has some symptoms, what's the waiting period for them to get an appointment to see the tertiary treatment?
Okay, so I think it varies according to the various setups in various hospitals, but certainly there is always going to be a outpatient service, and there'll also be the acute service. So obviously, depending on how unwell that patient is, then you need to make a judgment of who to contact first. For a patient like that who is clearly symptomatic with a palpable mass and who actually has had significant anemia, and she's symptomatic because she's got a pulse rate of 90, that's not normal for someone who is age 40. So I would argue that this patient actually warrants a more acute assessment. So in University Malaya, the patient can come to our walk-in clinic. So we have a walk-in clinic every day where there will be a specialist to review that patient. But clearly, if that patient is deemed to be unwell, too unwell in this situation, as what Dr. Faiza was relaying to us, then the patient naturally will need to go to emergency. And I'm really sad to hear that, Dr. Faiza has done all the right things. And not only did she encounter challenges and barriers to getting the right treatment for the patient, but she actually got scolded, which is not right. So I'm from the aspect of secondary care, I'm very sorry to hear that, Dr. Faiza. And this is what we really need to champion actually amongst specialists, actually, how we can actually do this and deal with this better.
Yeah, thank you very much, Prof. Kong. I think a very good discussion for the first case. We do have 2 more cases to go, but I suppose we can wrap up by saying that maybe the tertiary center has to be a little bit more welcoming, okay, to these cases, and more alert about this urgency of the cases. But also, I think we can also take a note that this patient might be one of those defaulters looking at the background of the psychosocial background of this patient. Okay, so sometimes when we send a patient off to somewhere that patient can't afford, there's a chance that patient might actually default. So luckily she went for the proper treatment. So let's move on to the next case where I think we will discuss more on the psychosocial as well as the palliative aspect. Okay, so we welcome Dr. Lee Ching Yu from Pahang Polyclinic and Surgery. Okay, the floor is yours. Thank you, Dr. Faiza.
How to control this one?
I think our person in charge can help out. Okay.
Yes, I'll be helping to move the slides. So you just
can you proceed with the next slide, please? My name is Dr. Lee. I'm from Kuantan. I run my own GP clinic. I would like to share this case. Thank you for picking this case of mine. All right. This is a 49-year-old man, a Chinese man. He is a known case of recurrent nasopharyngeal carcinoma, but with secondary to liver and decompensated liver disease, secondary to liver metastasis. All right. He has been referred to my clinic on the 14th December by the Chuji Foundations, and he was found to be breathless and with his abdominal distended. Right? And he claimed that at the hospital, nothing much was able to be done for him. So at my place, I checked on him, and I've noted that he has excessive cytic fluid, and I discussed with him that one of the way to reduce the breathlessness was to do a peritoneal tap, right? And he agreed with that. Actually, he has done that before in the hospital, and a little plus fluid was removed in my clinic. All right. In addition, at that particular time, psychological support was offered to him. And he was also offered the concept of mindfulness, the principle of mindfulness, and empathy. Empathy was incorporated during the consultation and treatment with him, listening to his grouses and his expectations. After the tap, he felt well. He was joy. He went back. He came back again on 23rd of December to our same clinic, and the fluid reaccumulated. Another cytic tap was done and removed a little plus of fluid. However, on the 29th of December, according to the contact, he passed away at home. Next page, please. So key learning points here is from the point of navigations. So when this patient was discharged at the hospital could and shall, when discharged, give a proper advice to whoever who these GPs or whoever health personnel is treating. I mean, would like to treat him. What are the measures that can be done for these patients? Whereas for treatment issues, there are much to learn to help to relieve patients suffering, though not curative. These patients suffer, cannot breathe well, and then there must be something that we can do to make him feel better. So I feel that the GP shall be empowered to learn more ways, especially in more procedures, confidently, so that this type of treatment can be offered to the patients in need. Financial issues wise, the patient did have financial issues, and he was assisted by Chuji Foundations, and he was actually charged minimal at the clinic. Next slide, please. So I would like to actually, based on this, I would like to share one of the article which was written by Prof. Liu Sume, titled Family Physicians in Possible Choice and Lesson Learned Through Illness. Prof. Liu was the professor in primary care in UN. I think a year or two ago, she was diagnosed with bladder cancer, and it was very unfortunate she succumbed to it. I still remember vividly, clearly, and I would like to read the quote that she said at the end of the of a paper. Quote, "If I were to speak to the younger me who wanted to do primary care medicine or decades ago, I would tell her not to think that she can prevent illness or cure one, but that she can listen and help the patients as much as he can, and offer empathy and kindness. Sometimes that's all that is needed, and it's more than enough. So with this, I really think that empathy and kindness is really needed in the realm of healthcare practitioner. We need more kind doctor, not doctors who keep on scolding the other doctors. Next slide, please. So a lot of things will be said of empathy. So actually, how do we put empathy into practice? All right, we say that you have to be empathy, but how do we actually do it in practical part? I would like to share here. One is active listening. Sometimes when we talk to the patients, we just have to keep listening to them, and then they will tell them the story, their concerns, their idea, what they want to expect. Then next, we can see how their feelings are being related, show them that we understand them and accept their feelings. Example, I can understand how you are feeling upset right now. The third is to paraphrase their statements. This paraphrasing also is very important, where we also shows that we understand them. So non-judgmental attitude, avoid personal bias and respect their beliefs, even choices as they're different from ours. All right. Example for this same patient who still smoke. So I have reflected, will I treat him differently if he still smoke? Because smoking is not good. But in the end, it's his choice. I have to respect him if he wants to smoke because he's terminal. No, I cannot just ask him to stop. Right. Fifth is the body language. We have to maintain the proper language, body language, where to show that we are actually in connection with our patient. Examples are eye contact, we nod our head, what crossing our arms or show signs on patients. The next is in GP practice, we really sometimes some of our clinics are really packed. All right, we are actually seeing our patient 5-10 minutes of that. We have to actually go to the next patient. So if we do have a busy schedule, if we can see him, we actually can bring him back, and make an appointment. We can spend about 15-20 minutes. No, I think not everything is monetary. We can actually offer more than monetary to our patients. Next is follow up. This one that our patient knows that after seeing them, we will still see them again and care for them. So ask them to follow up with us. That's all I would like to share. Thank you.
Thank you, Dr. Lee.
Yeah.
Sorry. Thank you, Dr. Lee. It's a very beautiful story that you have told us. It's very touching. This is something I think what we should, in the primary practice, should do. I still remember if you travel to certain countries, they have a private practice or the GPs with special interests. Some of them have interest in palliative, some of them have interest in surgeries or dermatology or something like that. I think we can, if you could introduce that in Malaysia, where patients like this can be handled by those doctors who have some specialties in certain areas. For in this case, I think it is more to a palliative kind of support. Any other views?
That's right, Dr. Siva. I think we are glad to have Dr. Shariza on board today. She's our palliative physician. So maybe we can hear from her what are the best approach. And I think there are also questions from the module before this, asking about, how do we get about for GPs to actually be involved directly with this palliative care. So I think we did give some response in terms of the hospice coverage. So maybe Dr. Shariza can share with us.
Yes, thank you, Dr. Teo, and thank you, Dr. Lee, for sharing this case. This is a very good example of somebody with at the end of the disease trajectory, and where he's terminal, where he wants symptom control and obviously emphasize into his quality of life. So when he comes in with symptoms of ascites, basically with who requires recurrent peritoneal tapping, we may consider in palliative settings putting in a permanent drainage for him, sending him home with a permanent drain, where we will teach the family members or even the carer on how to use or how to handle this peritoneal drain. And of course, I would say for this patient, he would have benefited from opioids to help with his discomfort and also breathlessness. So at the primary care level, I would say
we can start using opioids at any point. The most common available opioids will be syrup morphine and the cheapest. Ideally, the best for him would be transdermal fentanyl patch, which will be prescribed in the hospital or tertiary center. Even if you don't have any fentanyl, you can just start low dose morphine. Of course, the frequency of opioids may change depending on the liver function and also the renal function. Again, like you mentioned, he likes to smoke. At this point of time, we would have to balance between what is important for him at this end of life or terminal stage. If quality of life means having to puff 1 or 2 cigarettes a day, we should allow it, of course, with certain advice, not near an oxygen port, because sometimes when he's breathless, you may prescribe home oxygen for him. So all these precautions should come in place. In Kuantan, in the hospital Temerloh, there is a palliative, they are trying to set up a palliative unit there. However, some of the doctors there in the medical unit, I know, do some home visit, but there is no hospices covering areas in Pahang at this point of time. So we do still, I would say the first line would still be the general practitioner, the GPs, who have actually built good rapport with the patients over the years. So of course here, addressing the concern, having conversation with them, sometimes we don't need to spend hours with them, but just attentive listening to them about a few minutes would already be sufficient to them, just listening to their concern or even their worries. The thing is, sometimes we are not comfortable to ask, what are your worries? Do you feel? So we have to train ourselves or make ourselves comfortable with addressing this type of questions. Sometimes when patients say, patient also fear that we are in a hurry as doctors. So they sort of like, should I ask, should I not ask? But you should say, is there anything, any concern you want me to address? This should be something I would encourage everybody to, before the end of your consultation, to ask every patient. Otherwise, at this point of time, psychosocial is very important. Not only, Suchi is a very good organization, NGO who helps all around, but I hope more and more organizations should also help. And patients should not label just a society, this society is only for financial, or this society is for that. It's holistic. We should train all volunteers in any NGO into holistically managing the patient concern, psychosocial, spiritual, not in the sense of religion, but what is important to them, in their life at this stage of time. I hope I have enlightened, not to take too long. Dr. Teo, is that okay? Dr. Lee, is that okay?
Great explanation from you, Dr. Sheza. I think more extensive, and I'm sure that all of us will understand more that this type of patients need special attention. So maybe just a couple of words from our psychiatrist, our consultant psychiatrist, Prof. Ng Chong Guan. I think he's also here with us today. So is there anything you would like to comment about this case? Dr. Lee has tried his very best to arrange a separate session, like you said, if you have extra time to actually talk to the patient, spend a bit of extra time with the patient. Anything else to add to this case?
Yeah, thanks, Teo. Thanks, Dr. Lee. I think Sharissa have covered most of it. I think it will be great if this part of the duty can pass over to the primary care doctor or the general practitioner. I think it's quite a stressful experience for the family and the patient to go through their end of life. Even worse if they heard that I need to go and see a psychiatrist now. So if we can empower the primary care to take over this part, that will be very great. But I understand, as Dr. Lee said, not many people interested in palliative care in the primary care setup, because you take a lot of time, a lot of effort, and also will really impair their psychological or their mental well-being of the doctor. So for those who are really interested, try to get some experience, do some attachment series to see whether they like it or not. We can't force everyone to take up this palliative care treatment. Actually, sometimes it's more painful than physical pain when you take care of someone that is dying. And just like Dr. Lee said, after a few days, you give them a call, then you realize they just pass on. Actually, it's quite a heavy feeling. So take care of your own mental health well if you really want to get involved in this end of life care. This is my suggestion.
Definitely, I mean, with Prof. Ng saying that you can come for attachment. Yes, there have been primary care GPs coming to our palliative unit for short attachment, a week or even a few days, to just see what we normally do for patients at their disease end of their disease trajectory or at their terminal stages. So I welcome any GP who wish to do attachment with palliative unit in PPUM. Yes.
Dr. Shariza, may I ask if there are any certificate courses in the pipeline for GPs
at the moment in UM, no, we don't, but there are, like in Hospice Malaysia, they do workshops such as carer workshop, grieving workshop, or even communication workshop. So these are courses that they arrange throughout the year. So if at any point, because Hospice Malaysia has a well-formed education program for palliative in the community, please just visit their website to look at all the information where they have workshops. Other than that, in UM we do occasionally do, recently we had train the trainers for the nurses. In future, there will be for other general physicians or even primary care, but not the date is not there yet. So maybe I will put it in the website, yes, in the UMMC website.
Okay, due to the time constraint, because we are almost at the end of our session, we will not be able to discuss the third case, all right? But anyway, I think the case has some part of the discussion from the first one. So I shall just open the floor for any questions to Prof. Pang regarding the lung cancer, and as well as Dr. Ahmad for any burning questions on prostate cancer. So please feel free to fill up the Q&A box now, or you can ask verbally in this meeting. Or maybe, Christine, did you encounter any questions from the
Yes. Thanks, Dr. Teo. While we wait for the questions to come in from the audience, I did encounter a few questions during the course of the module along pretty much the same themes. If you recall, Prof. Pang, there were quite a number of questions on the screening offered to high-risk patients who are at high risk of lung cancer. In what situations and in what sort of a setting would it be a good idea to offer a low-dose CT? So quite a few questions came up with regards to which centers can offer these particular CT scans, and if there are any private centers working in partnership with us to offer these low-dose CT scans.
Thank you very much, Christine, for asking the question over here. Well, I think low-dose CT scan, theoretically, there are many hospitals which can provide this kind of service. But unfortunately, for low-dose CT scan screening for lung cancer, it's not actually just the CT scan that we are talking about. It's actually a whole package of screening. I think the most important part is still actually the counseling and also identifying those who are suitable for screening. At the moment, I think based on evidence-wise, the screening is only limited to those who are at risk or at high risk. At high risk means that based on the previous low-dose CT scan study, either the lung cancer screening trial or the Nelson study, and hence I think usually they will use the criteria or those who are above 50 years old and with history of heavy smoking, like 30 pack a year. But also, I think suppose we can also extend this to those with high risk, meaning that those with family history of lung cancer or any other cancer, but 20 pack a year above 50 years. But we know that lung cancer will not just affect people who are smoking, but also may affect people who did not smoke. So this is actually the tricky part. How do we screen people with family history, a strong family history of cancer, but they did not smoke? So this is the issue that are not addressed by the previous studies. So we really do not have a clear-cut answer for this. But for heavy smoker, I think we know that there are benefits of low-dose CT scan screening, like the one done in the US, whereby they recruited I think more than 50,000 individuals in their trial. The Nelson is more is done in the Europe. So also I think the criteria is more or less the same. The one in America, the screening involved 3 separate low-dose CT scan done at 0, 1, and 2 years. And then the one done in Europe, I think, involved 4 CT scans done over the follow-up period. So to me, I think if someone needs to do the low-dose CT scan screening, I have no objections to this idea, as long as they fulfill the criteria. But more importantly, as I alluded earlier, if we are going to embark on the low-dose CT scan screening, I think we need to ensure that we are quite familiar with the screening process, how to counsel the patient before embarking on this screening program. And also, we also need to ensure that patient know the potential benefit and potential. There are some actually so-called potential disadvantage as well. Because some patients, once they go into the screening, if they find something, they become super anxious, right? So it's not totally like a benefit. So we must take into consideration what are the potential disadvantage, and then you must counsel the patient, and they need to know all these things beside the financial implication. And also there is a possibility that if they go for screening, they may detect some unrelated lung nodules, which will worry them very much, and they may need to go for some other procedures. So meaning that the 3 or 4 CT scan is not the ultimate procedure that patient have to go through. If we detect some nodules, patient may have to go for some additional CT scan or other invasive procedure to find out the nature of the nodules. So these are the things that we need to discuss with the patients. Of course, you just look at the study, there are probably 20 to 24% survival benefit. But I think provided this is done properly. But I think they following all this screening trial, in fact, there are many studies done after that to look at actually the processes. They found that many people are not being well trained to do all this low-dose CT scan screening. You see, so I think, and also the radiologists play a very important role because when you see a small nodules, the radiologist sometimes is in the dilemma whether to label this as a significant nodule or not to label this as a significant nodule, because the trial actually take a very small nodule into consideration. Anything that is 4 mm and above is considered significant. So, and then we know that we are living in a country whereby TB is still quite endemic. So it's quite likely to pick up some unrelated nodules. And that for that, it may actually result in more anxiety to the patient and possibly also more intervention. But I think I'm actually more towards actually early diagnosis of symptomatic patients, because the screening, I think, involve quite a lot of resources. So I think many public hospitals are not ready to perform the low-dose CT scan screening yet, because I think the services are already overwhelmed with patients with other respiratory disorder, including the symptomatic lung cancer. So, and also counseling takes up a lot of time. Private hospital, I'm not too sure about their workload. Perhaps that they can actually consider, and the patient is quite keen to go for screening. I think I have no objections, but please make sure that we counsel them properly. That's my take on this.
Thank you very much, Prof. Pang, for summing up very nicely with regards to the low-dose CT scan, because this is a relatively newer modality of screening as opposed to other common tests that we are quite familiar with. So, making sure that it's a shared decision to be made at the end of it. Yeah. Thanks very much, Prof. Pang. On that note about decision-making, may I call upon Dr. Ahmad Nazran to sum up a little bit about PSA screening? I mean, it's a topic that has come up several times, but the question does still arise with regards to approaching it in an appropriate manner. So that is one. There is another question that has come in with regards to prostate specific antigen, where there are some labs that report not just the PSA level, where we aim for less than 4, but also the PSA ratio. Is that a figure that that you would pay attention to or be worried about if it's slightly increased?
For the question. Thanks to our organizer. I hope everybody is finding this session useful. Second question first might be easier. Okay, so there's a lot of derivatives of PSA. There's the PHI index, there's the PSA total free PSA ratio, there's the PSA density. Okay, so in terms of cancer screening, most of we don't really use all those so much, okay, because free total PSA ratio also can vary quite widely. I mean, they did show that if you have a low ratio, higher risk of prostate cancer, but this is only for small size prostate. Okay, so it doesn't apply to large prostate per se. So that's why we don't use it so much. PSA density, although not used as screening, has been used particularly in some of these calculators for saying those with high PSA density have a higher risk of prostate cancer. But again, those in these calculators, not really for what we use for screening. So unfortunately, to cut the story short, we don't use that. Okay. I mean, of course, you hear things like PSA velocity, but that's more useful for cases that have already been diagnosed with prostate cancer. And it's quite useful to decide sometimes what treatment to use. Those that PSA progresses rapidly, whereas those where PSA progresses slowly, the treatment may actually be different. Okay, in biochemical recurrence post-prostatectomy. Okay, so as said, you can hear from a lot of other cancers, breast cancer, lung, colorectal cancer, that they have shown that PSA screening, screening for the relevant cancer has been shown to have improvement in mortality, detecting earlier and hence reducing the mortality and better outcome for the patients. Unfortunately, it's not so simple in prostate cancer for two reasons. Number one, PSA, as I think most of the GPs are aware, is not a perfect test. It's prostate specific, but it's not cancer specific. A lot of things can be raised with PSA, and that's why it's not exactly the perfect screening test. I think Dr. Christine in your lecture also mentioned that generally tumor markers are not really the best thing, but unfortunately, at the moment, that's all we have for prostate cancer. Okay? So the other problem with prostate cancer is that we have the indolent form of prostate cancer and the aggressive form of prostate cancer. So a lot of these screening studies have been shown, I mean, in terms of the PLCO trial in the US, as well as the SPC trial, a lot of them have shown that, the Cochrane systematic review, the database of systematic review shown that a lot of the screening pick up higher indolent cancer. Indolent means your Gleason 3+3 lah, or your ISUP1, the new classification. So they tend to pick those one up more rather than the clinically aggressive prostate cancer, and hence, of course, they have an increased incidence of prostate cancer, but that's why most of the screening studies do not actually show actual improvement in mortality. Okay. So that is the inherent problem with PSA. So that's why, as most cancers as well, we talk about shared decision making in asymptomatic patients. It's different if patient is symptomatic. If they have LUTS, the hematuria, that is symptomatic patient. That is not screening anymore. Okay, so in asymptomatic patient, you really need to sit down and talk to the patient, because you can cause a lot of anxiety. I think Dr. Christine mentioned in the study, that even though the biopsy come back is negative, they still wonder, will it be false negative biopsy? Could I actually have cancer inside? Just the technology cannot detect it yet. Okay, so it can cause a lot of anxiety. Not to say that it's not good, okay, because you want to catch cancers early so that you can provide them cure. The same applies to prostate cancer. We know stage 1, 2, 3. The survival is more than 90%, whereas stage 4. So definitely there is a role for screening, but currently, unfortunately, we have a screening tool. It's not perfect. So I think you really have to sit down and discuss with the patient about the pros and cons before you embark on PSA screening. I think that will be my take.
Thank you, Dr. Ahmad, for highlighting us the importance of PSA, and it should not be treated as a cancer marker per se. We had a very good section today. Thank you all to all the speakers who contributed. I'd like to personally thank Prof. Aisha and the team of REBUNG, who have really took trouble to educate the primary care doctors. Hope this is a win-win situation, not for us doctors, but also for the patients as well. I think that is our ultimate aim. Before we sign off, can we, all those who are here, please on your camera so we can take a group photo. Okay, okay. The admin got the photos? Okay, and before we wrap up the night, can I pass back to Prof. Aisha to have the final words for tonight?
Yeah, thank you, Dr. Siva, Dr. Teo, and Dr. Christine for the good case discussion. Next, I'd like to invite our pillar of this project, Professor Suniza, to deliver her remark, and then let's welcome Professor Suniza.
All right. Can you see my closing remarks?
Also mention something because
Prof, do you mind I just
Sunisa, maybe I could just give heads up for the
go ahead, Prof.
You'll be doing the closing remarks, but I think I better mention to the GP in the course that will be in the pilot site. So we will be contacting you soon to see how we can 40 clinics to actually deliver a screening to the B40 community. All right, so we'll be contacting you soon. Don't worry. All right, Suniza, over to you.
Okay, thank you very much, Prof. Aisha, and thank you very much for all the participants and all the expert panel had attend and then make this event success. So I just make a few remarks on my my closing remarks. So hopefully by the end of the course, everyone knows what are the signs and symptoms of cancer for most 5 top cancers in Malaysia. So by the end of the course as well, I hope that everyone knows how to identify the diagnostic care pathway, after detection of symptoms or abnormal cancer screening, and recognize your role as a healthcare professional in cancer care. You are very important. You are the first person that will be seeing the patient, and identify the approach for the provision of psychosocial support, and also identify the cancer support program that is available in Malaysia. So the total number of participants supposedly to attend today is 94, but I think we only have 56 in our count. But the good news is these are the things that course completion criteria. So you will, at the end of the course, you will get a 23 CPD points and also a certificate if you completed the pre and post assessment questionnaires, a feedback form for each module, provided case that related to any issue or barrier in early cancer diagnosis, and attended both introduction and closing event. And of course, some of you might not be able to attend. We will upload the video for tonight, okay? And also, you may receive an email to assess the effectiveness of this course, probably at 4 months or 12 months after this. And the good news is we are going to extend the open learning, since I think that most of you haven't completed the module. So I think busy with the Raya, you know, with a lot of holidays. It's okay, we give 1 more month for you to do a revision and also to complete the whole course. So I hope that you guys get an opportunity for another 1 more month to complete this this course itself. So I think with that, I end my my closing remark with thanks, and I hand over to our MC, Dr. Wilson.
Thank you, Prof, for the kind remark, and I hope everybody enjoyed the night tonight. So let's get a quick group photo.